Hello and welcome to the INI-CET Rapid Recall. I am Dr. Yusuf Ali Tyagi. The topics that we have to cover are the pediatric orthopedics and the nerve injuries. The topics that we have to cover for this rapid INI-CET recall. You know, whether you are aware of it or not, in orthopedics, there are only 26 topics. I'm not talking about chapters. Only 26 are the numbers of the topic, जिसमें से सारे INI-CET orthopedics के questions बनते हैं. उनमें से ऑलमोस्ट अराउंड मीन्स आउट ऑफ दोज मल्टीपल टॉपिक्स जो पीडियाट्रिक एज वेल एज नर्व इंजरी से रिलेटेड जो कंपोनेंट है द टॉपिक्स दैट वी आर गोइंग टू टॉक अबाउट ऑलमोस्ट ऑल द क्वेश्चंस आर आस्क्ड आउट ऑफ दिस फ्रेम ओनली, राइट? सो लेट्स talk about the first one, that is nerve injuries. You know, the table on your screen, almost every question related to the nerve injury is directly or indirectly associated with this table. इस टेबल में हो क्या रहा है बेसिकली इज कि कौन सी बोन कहाँ फ्रैक्चर हुई, कहाँ इंजरी हुई और उस इंजरी की वजह से कौन सी नर्व का इम्पैक्ट होगा. सो हाउ दीज क्वेश्चंस आर बेसिकली स्ट्रक्चर्ड इन दिस INI-CET एग्जाम इज दैट दे विल गिव यू अ फ्रैक्चर एंड आफ्टर द फ्रैक्चर प्रोवाइडेड टू यू, you should be aware of that, you know, with this kind of a fracture, the nerve that could be injured is this. For example, if there is a fracture in the shaft of the humerus, then you should be aware कि ये fracture shaft of humerus की वजह से radial nerve could be likely injured. और उस radial nerve की injury को identify करने के लिए you should be knowing about that what will happen if the radial nerve is injured at this level. So all these things are provided to you in the question. You know, they will give you the etiology. उस etiology के basis पे there is an assessment whether you are aware that the nerve related to this particular bone injury is likely to get injured. Then are you aware of the outcomes of that nerve injury? That means diagnosis. And some of the time the question is pushed forward to an extent where they will ask about the management of that particular nerve injury. So all these questions are structured in the same way. So many questions which have been previously asked, like fracture in the proximal pole of the fibula, fracture in the proximal humerus, fracture in the distal end of the humerus, fracture of the mid shaft of the humerus, right? Dislocation of the shoulder, dislocation of the hip joint, dislocation of the elbow joint. So they will give you a structured question in the form of the etiology, seeking for the diagnosis, and some of the times even management. So let's talk about this one by one. ये टेबल है जिसमें कि हमने सारी इंजरीज को डिस्कस करा है और इन्हीं इंजरीज से हाउ द नर्व इंजरीज आर फाउंड टू बी एसोसिएटेड विद दिस इज एग्जैक्टली व्हाट वी आर गोइंग टू टॉक अबाउट. लेट्स टॉक अबाउट द फर्स्ट वन और द फर्स्ट एग्जांपल. लाइक if you can very clearly see that there is a fracture in the proximal humerus in this image, that there is a fracture of the proximal humerus. Now all of you right from the first year are aware of your, throughout this medical journey of yours, right in the first year you are aware कि अगर proximal humerus में कहीं इंजरी होती है, then the name of the nerve which is likely to get injured is the axillary nerve. All of you are aware, axillary nerve, because it is related with the neck of humerus, and if there is a fracture in this region in particular, then there is a likely possibility that there is going to be an injury to the axillary nerve, right? Similarly, another etiology is dislocation of the shoulder. Like if there is a dislocation of the shoulder in the form that, like, it could be dislocated anteriorly, it could be dislocated posteriorly, it could be dislocated inferiorly, then there is always a possibility of a stretching of this nerve, and this stretching or a tractional injury to the nerve might result in axillary nerve injury. Another possibility, another likely question that could be framed because of, or the etiology that could be framed in the axillary nerve related question is the intradeltoid injections. You know, if you give the injections in the deltoid muscle, which is a site for intramuscular injection in the upper limb, so there is always a possibility that there could be an impingement of the axillary nerve while inserting that needle inside. So intradeltoid injections might also result in axillary nerve injury. तो ये आपको etiological forms मिलेंगे axillary nerve injury से related. दूसरी बात that you should be knowing about or you should be aware of are what are the outcomes of axillary nerve injury. अब आप सबको मालूम है कि axillary nerve is responsible for supplying the deltoid muscle, and deltoid is responsible for abduction of the shoulder. So continuation of the abduction of the shoulder is the function of the deltoid muscle. If axillary nerve is injured, then it will lead to deltoid palsy. And because of this atrophy of the deltoid muscle or no use of the deltoid muscle, there will be limitation of abduction, वीकनेस इन द एबडक्शन ऑफ द शोल्डर, तो ये सारे क्लिनिकल फीचर्स मिलेंगे आप. अपार्ट फ्रॉम दिस, एक्सिलरी नर्व इज ऑल्सो रिस्पॉन्सिबल फॉर सप्लाइंग द अपर लैटरल एस्पेक्ट ऑफ द आर्म. और ये जो रीजन होता है इन द अपर लैटरल एस्पेक्ट ऑफ द आर्म, दिस रीजन is under the sensory supply of the axillary nerve. And you know, it is correlated with the regiments, क्योंकि regiments, armies में जो regiments होते हैं, for the identification of those regiments, badges are provided in the sleeves of the uniform. And this is the reason why it is called by the name of regimental badge sign. So these are the things which you already are aware of. So how the question is structured in this INI-CET exam related to the axillary nerve injury, कि आपको एक इटियोलॉजी मिलेगी, या तो प्रॉक्सिमल ह्यूमरस का फ्रैक्चर मिलेगा, या फिर प्रॉक्सिमल डिसलोकेशन ऑफ द शोल्डर मिलेगा, या फिर इंटरडेल्टोइड इंजेक्शन मिलेगा. तो इटियोलॉजी को बाद देन दे विल गिव यू अ क्लिनिकल फीचर लाइक वीकनेस इन द एबडक्शन, कंटिन्यूएशन ऑफ द एबडक्शन इज लॉस्ट, और देयर कुड बी लॉस ऑफ सेंसेशंस ओवर द अपर लैटरल एस्पेक्ट ऑफ द आर्म व्हिच इज नोन बाय द नेम ऑफ रेजिमेंटल बैच साइन. And then they will seek for the answer that what is the name of the nerve which is likely to be injured in this case. Answer for that question is, obvious answer is axillary nerve injury. So this is one point. Nerve injury से related एक axillary nerve injury पे बहुत common एक question पूछा जाता है, right? Apart from this, now you already know that in the distal 1/3 of the humerus, that means in the supracondylar region या supracondylar fracture, if there is a supracondylar fracture in this region, then the name of the nerve which is likely to get injured is the anterior interosseous nerve. And this anterior interosseous nerve is a branch of the median nerve. And there are lots and lots of the questions which are asked in this perspective. कि आपको X-rays are provided and then they are asking what is the name of the nerve which is likely to be injured in this case. So you have to identify the fractures on the X-ray. As it is very clearly evident over here कि this is the supracondylar region, and if there is a fracture in the supracondylar region, then it will be called as supracondylar fracture. So, like this is the humerus, the supracondylar region of the humerus, and this is the distal end of the humerus, and it is fractured. Now, because of this fracture, there is a likely possibility or likely injury to the anterior interosseous branch of the median nerve. And the median nerve is tested like, what are the names of the test through which median nerve is tested? One is pen test. Already you know that what you do in pen test, you ask the patient to abduct the thumb and touch the pen by abduction, because abductor pollicis brevis, that means abductor of the thumb, is supplied by median nerve. Imagine if median nerve is injured, patient won't be able to lift the thumb in abduction. That is pen test positive. So it can be given to you in the question. Another one is pointing index. Now this also you are very much aware that this index finger flexion of interphalangeal joint is entirely a function of median nerve, because flexor digitorum profundus as well as flexor digitorum superficialis, both of them are supplied by the median nerve for this index finger. So what will happen when you ask a patient to form the fist? One of the finger remains pointed, and that is the reason why it is known by the name of pointing index. तो आपको एक etiology देने के बाद they can give you the clinical features in the form of pen test. They can ask for the pointing index, and they can also ask for the Kilonavin sign. What is this Kilonavin sign? Where it is also known by the name of wow sign. Now what is happening in this? आप flex करते हो interphalangeal joint of the thumb, आप flex करते हो interphalangeal joint of the fingers, and you try to create a sign of wow. Now, this entire is a function of the median nerve. This one is a function of the median nerve. If the patient is having a median nerve injury, then he won't be able to bring it into approximation. वो ढंग से उसको approximate नहीं कर सकता because of the loss of flexion of the interphalangeal joint of the thumb. Flexion of interphalangeal joint of the thumb is the function of flexor pollicis longus muscle, which is supplied by the median nerve. अभी हमने थोड़ी देर पहले देखा कि फ्लेक्शन ऑफ द इंटरफैलेंजियल जॉइंट ऑफ दिस इंडेक्स फिंगर इज आल्सो अ फंक्शन ऑफ मीडियन नर्व, क्योंकि वो फ्लेक्सर डिजिटोरम सुपरफिशियालिस को भी सप्लाई करता है और फ्लेक्सर डिजिटोरम प्रोफंडस के लैटरल स्लिप को भी सप्लाई करता है, राइट. सो दिस इज हाउ द क्वेश्चन इज स्ट्रक्चर्ड फॉर द मीडियन नर्व इंजरी. उसमें पेन टेस्ट हंड्रेड्स ऑफ द टाइम्स हैव बीन आस्क्ड, राइट. सिमिलरली और इटियोलॉजीज हो सकती हैं रिलेटेड टू अल्नर नर्व इंजरी, लाइक there could be a dislocation of the elbow. Ab, with the dislocation of the elbow, or the dislocation of the elbow does not exclusively results in ulnar nerve injury, लेकिन dislocation of elbow की वजह से ulnar nerve injury होती है. posterior interosseous nerve injury भी हो सकती है, median nerve injury भी हो सकती है, but majority of the time it is ulnar nerve which is getting injured because of dislocation of the elbow. होता है, it is common. So this could be the etiology. Another one is lateral condyle का complicated fractures like non-union fractures of the lateral condyle. So non-union fractures of the lateral condyle, ये एक complicated factor है, which will result in cubitus valgus deformity. Now this is the cubitus valgus deformity where the apex is pointing towards the body, right? And this valgus, ये ज़्यादा excessive valgus होने की वजह से there is a compression as well as stretching, compressive as well as tensile injury to the ulnar nerve जो कि medial border पे है. It is a result of the excessive cubitus valgus beyond the carrying angle. So cubitus valgus could also be provided to you as a etiology for ulnar nerve injury, right? As you can very clearly see, if you go back to this table, जैसे आपने देखा कि elbow dislocation की वजह से ulnar nerve injury होती है commonly. So what next they can give you in the ulnar nerve injury is the identification. Like book test, they can give you book test. This is actually a book test. जहां पे आप क्या टेस्ट कर रहे हो? Adduction of the thumb. That you are asking a patient to adduct the thumb and hold the book, as if when you try to pull the book out, if the patient is not able to apply adequate resistance, इसका मतलब adductor pollicis brevis, that means adductor of the thumb which is supplied by the ulnar nerve is lost, right? That is book test. So book test में आप जो टेस्ट करते हो वो क्या है? Adduction of the thumb. And sometimes this is also been asked, ये भी आपका रखा जाता है options के अंदर, where instead of performing adduction of the thumb, the patient tries to hold the book tightly or hold any object tightly by flexion of interphalangeal joint of the thumb. And this flexion of the interphalangeal joint of the thumb is a function of the median nerve. So book test को modify करता है patient into Froment sign. So ulnar nerve से related जो क्लिनिकल आइडेंटिफिकेशन है वो फ्रॉमेंट साइन दिया जा सकता है, बुक टेस्ट दिया जा सकता है. सिमिलरली अनदर टेस्ट विच कुड बी प्रोवाइडेड टू यू इन द क्वेश्चन इज द कार्ड टेस्ट, जिसमें कि पेशेंट इज आस्क्ड टू होल्ड द कार्ड और एनी ऑब्जेक्ट इन बिटवीन द फिंगर्स बाय एडक्शन, एंड एज एन एग्जामिनर यू आर ट्राइंग टू पुल दिस ऑब्जेक्ट आउट. इफ द पेशेंट इज एबल टू अप्लाई रेजिस्टेंस, इसका मतलब the palmar interosseous muscles which are supplied by the ulnar nerve are normally functional. This is known as card test. So this is the test for palmar interosseous, right? And which is also supplied by the ulnar nerve. And palmar interosseous are innervated by the ulnar nerve, and the function of the palmar interosseous is adduction of the fingers. तो वो adduction function को test करके आपको question में दिया जा सकता है. Apart from this, claw hand could also be provided to you in the question. As you know, how claw hand is identified? Loss of lumbrical function. Like there will be hyperextension of the metacarpophalangeal and flexion of the interphalangeal joint. So lumbrical function loss होगा. So this is how the questions are structured. आपको एक etiology दी ulnar nerve injury की, और उसमें card test दे दिया, book test दे दिया, claw hand deformity दे दी, and then they are seeking for the answer, and the answer for that question is ulnar nerve injuries. Now what is the name of the splint which is used for this ulnar nerve injury? It is Bunnell knuckle bender splint. So sometimes this splint only is or could be asked in your question, जहां पर knuckles are bent and then immobilized in order to prevent this claw hand deformity from getting permanent. क्योंकि patient lumbrical function में अपने palm को नहीं ला सकता, so it will result in a claw hand deformity which will get permanent अगर उसको immobilize नहीं करा in the direction of the lost function, and that is achieved by the placement of this paralyzed hand in the knuckle bender splint because of ulnar nerve injury, right? So this is another question. Like if you go back to what we have discussed till now, और हमारा जो scene क्या है पूरा, in order to understand the entire phenomena कि question कैसे आपके बनाए जाते हैं, उसमें आपको एक etiology दी जाती है. उस etiology में वहां पर कहीं आसपास कोई एक नर्व इंजरी हो रही होती है, उस नर्व इंजरी के क्लिनिकल फीचर्स दिए जाते हैं, राइट? तो वो etiology आपको मालूम होना चाहिए. क्लिनिकल फीचर्स ऑफ द नर्व यू शुड बी नोइंग अबाउट. जैसे हमने डिस्कस करा एक्सिलरी नर्व के लिए, if with the proximal humerus fracture, supracondylar fractures with median nerve injury, and similarly the cubitus valgus or the fractures around the medial epicondyle or the dislocations of the elbow will result in the ulnar nerve injury और इनकी obvious findings. Similarly, अगर कहीं fracture होता है shaft of the humerus में, now you already know that the radial nerve is closely approximated along the long axis of the humerus. और अगर humerus में बीच में कहीं shaft of humerus होता है, then it will result in radial nerve injury. And this radial nerve injury is identified as wrist drop. जो high radial nerve injury होती है above the level of elbow, उसके अंदर the extension of the wrist is lost and the patient presents with the wrist drop or the metacarpophalangeal joint extension loss. So इसको immobilize करने के लिए, in order to prevent this deformity from getting permanent, आप immobilize करते हो into extension, and this extension of the wrist is achieved by the cock-up splint. So this is how you will identify a cock-up splint, right? So this is how the questions are structured for the radial nerve injury. आपको mid 1/3 humerus का fracture दिया या उसके management से related outcome मिला कि patient is not able to extend the wrist or extend the metacarpophalangeal joint of the fingers. As a result of which, the radial nerve is injured, and in order to prevent this deformity from getting permanent, you are immobilizing it into a cock-up splint in the position where the movement is lost, right? So cock-up splint is used in case of radial nerve injury. Similarly, एक ऐसा fracture आपको दिया जा सकता है जो कि आपको identify करना हो. Like what is happening over here is the fracture of the proximal ulna. There is a fracture in the proximal part of the ulna, and along with it, there is a dislocation of the elbow. So if you combine this dislocation of the elbow and fracture of the proximal ulna, both of them, then the answer for this question becomes Monteggia fracture dislocation. So this is Monteggia fracture dislocation. And in Monteggia fracture dislocation, the most common nerve which is likely to get injured associated with this is the posterior interosseous nerve. Posterior interosseous nerve. So, एक आपको एक्सरे दिया जा सकता है of the Monteggia fracture dislocation, and then they can give you the clinical features of the posterior interosseous nerve injury, which are going to be like, what are the clinical features associated with this? Is inability to extend the metacarpophalangeal joints of the hand. Extension of the metacarpophalangeal joint of the hand is lost, which is because of the posterior interosseous nerve injury. And along with it, there will be no sensory loss. Why there is going to be no sensory loss? Because the posterior interosseous nerve is a pure motor nerve. Actually, it is a branch of the radial nerve and it is a pure motor nerve. So there is going to be no loss of sensations over the first dorsal web space of hand, जो कि आपको radial nerve में majority of the times मिलती है. Right? So this is how the question could be structured for posterior interosseous. So what I'm trying to say is that today they are not asking the one-liner, like what is going to be the pen test for, what will be the card test for, what is pointing index, what is Kilo-Nabin sign. They are giving a core clinical question जहाँ पे etiology is provided, the clinical features are provided, and then they will ask you what is the nerve which is injured related to this particular condition. राइट तो अगेन जो पोस्टीरियर इंटरऑशियस नर्व इंजरी अगर होती है तब उसमें भी आप उसमें द पेशेंट इज प्रोवाइडेड विद द कॉक-अप स्प्लिंट. एज फार एज मैनेजमेंट ऑफ दिस कंडीशन इज ऑल्सो कंसर्न, आप इसमें भी कॉक-अप स्प्लिंट प्रोवाइड करते हो एंड यू वेट फॉर सम टाइम बिकॉज द प्रोग्नोसिस इज रिलेटिवली गुड, राइट, बिकॉज इट इज अ पार्ट ऑफ द इफ देयर इज अ डिसलोकेशन ऑफ द हिप जॉइंट and you know the majority of the time the dislocation of the hip, the common one is the posterior dislocation of the hip. And if there is a posterior dislocation of the hip, you have to identify whether it is anterior or posterior on the x-rays. And on the x-rays, you have to know that the dislocation attitude, that if the hip joint is dislocated posteriorly, तो उसका attitude आपको मालूम होना चाहिए. And the attitude for the posterior dislocation of the hip joint is flexion, adduction, and internal rotation along with shortening of the limb. And here, as you can very clearly see that the thigh seems to be adducted, although आप flexion में thigh गई है या नहीं गई है उसका नहीं पता सकते. To some extent, you can know about internal or external rotations based upon the visualization of the lesser trochanter, as it is internally rotated. So lesser trochanter is not clearly visible. But आप एडक्शन से पता लगा सकते हो कि वेदर द डिसलोकेशन इज एंटीरियर और पोस्टीरियर बिकॉज द हेड ऑफ द फीमर इज आउट ऑफ द एसेटेबुलम, राइट? सो पॉसिबली इट इज द एक्सरे ऑफ पोस्टीरियर डिसलोकेशन ऑफ हिप, बट उसको आइडेंटिफाई करने के लिए एटीट्यूड इज समथिंग दैट यू शुड बी नोइंग अबाउट. एंड वंस यू हैव रियलाइज्ड इट टू बी पोस्टीरियर डिसलोकेशन ऑफ द हिप जॉइंट, then the name of the nerve which is likely to get injured is the sciatic nerve. Now this is not something which is very difficult. ये बहुत easily you will identify that the name of the nerve which is likely to get injured is the sciatic nerve. So this is how the question is structured for the sciatic nerve injury. Similarly, the common peroneal nerve injury. All of you know that the name of the nerve which is lying in close approximation with the proximal aspect of the fibula is the common peroneal nerve. सो ये कॉमन पेरोनियल नर्व इंजरी के लिए आपको जो क्वेश्चंस मिलेंगे वो मिलेगा या तो फ्रैक्चर ऑफ द प्रॉक्सिमल फिबुला और द स्टैब इंजरी इनटू द प्रॉक्सिमल एस्पेक्ट ऑफ द नी जॉइंट ऑन लैटरल सरफेस और द गन शॉट onto the knee joint on the lateral surface. So all these injuries will mount to build up the expectation that possibly the question related to common peroneal nerve injury is asked. Now if the common peroneal nerve is injured, then the name of the muscle which is paralyzed is tibialis anterior, which is the major dorsiflexor of the ankle, and if the patient is not able to dorsiflex the ankle, it will result in foot drop. This results in foot drop. और foot drop होने की वजह से the patient won't be able to walk normally and the patient will be presented with the high stepping gait. High stepping gait. So basically now what the sort of the questions which are asked today actually are the small clinical profile provided to you in the question, and then they are asking about the diagnosis. So patient will be presenting with the high stepping gait. He will be presenting with inability to dorsiflex the ankle. So once you have identified these clinical features, the diagnosis is made, and the diagnosis is that of a foot drop. And in order to prevent this plantar flexion from getting fixed, the foot is immobilized in a neutral position, and that neutralization of the ankle is achieved by ankle foot orthosis. Ankle foot orthosis, or you can say ankle foot splint. So these are the simple types of the questions which are getting asked. ठीक है, नर्व इंजरी से रिलेटेड जो क्वेश्चन है वो बोन की इंजरीज, मस्कुलर इंजरीज or the injury to the part of that limb, and then they are asking the clinical features. On that basis they are asking abnormalities, right? One thing that you should also be knowing about is actually the classification system for the nerve injuries, जो कि Seddon system of classification है, Sunderland system of classification है. In huge detail we have already talked about it. लेकिन if we go on revising what we have discussed right now, that just now what you came to know about, that as in the beginning I told you that this is the nerve injury और ये इसके मीन्स दिस इज द इंजरी और उसमें कॉमन नर्व कौन सी इन्वॉल्व होती है. नाउ इफ यू रिवाइज दिस टेबल नाउ, दैट शोल्डर डिसलोकेशन के साथ एक्सिलरी नर्व, तो एक्सिलरी नर्व के क्लिनिकल फीचर्स आपको मालूम होना चाहिए. फ्रैक्चर ऑफ द प्रॉक्सिमल ह्यूमरस, अगेन एक्सिलरी नर्व. फ्रैक्चर शाफ्ट ऑफ द ह्यूमरस, रेडियल नर्व, उसके क्लिनिकल फीचर्स और मैनेजमेंट भी आपको मालूम होना चाहिए. सुप्राकंडाइलर फ्रैक्चर ऑफ द ह्यूमरस, मीडियन नर्व, उसके भी क्लिनिकल फीचर्स आपको मालूम होने. एल्बो डिसलोकेशन, अल्नर नर्व, clinical features and the management you should be knowing about. Monteggia fracture dislocation, posterior interosseous nerve, just now we have talked about. Volkmann ischemic contracture, again anterior interosseous branch of the median nerve, जिसमें कि kilonavin sign positive आया था. Posterior dislocation of the hip joint, again sciatic nerve. The wrist dislocation, median nerve, is the nerve which is likely to get affected, and you should be knowing about the features of the median nerve. Then knee dislocation or injury to the knee, common peroneal nerve. So these are the features that you should be knowing. और सारे के सारे क्वेश्चन रिलेटेड टू नर्व इंजरीज आर असाइंड इन दिस. जैसे मैंने बताया कि ओनली 26 आर द नंबर ऑफ टॉपिक्स, आई एम नॉट टॉकिंग अबाउट चैप्टर, 26 आर द नंबर ऑफ टॉपिक्स इन ऑर्थोपेडिक्स, जिसमें कि सारे क्वेश्चन आपके INI-CET के बनते हैं, राइट? देन कमिंग ऑन टू द पीडियाट्रिक ऑर्थोपेडिक्स, और जैसे आपने देखा है कि फॉर द लास्ट 3 years consistently they are asking a question in NEET PG examination, in whatever the sort of examination they are conducting, NEET PG examination, the INI-CET, they are talking about, they are asking about this CTEV. What is CTEV? It is congenital talipes equino varus, right? अब उसमें ये एबनॉर्मैलिटी ऑफ द फुट आपको दिखाई देती है, ऑन द बेसिस यू विल मार्क द आंसर. बट व्हाट वी वांट इज कि आप इस एबनॉर्मैलिटी को याद मत रखो, आप इस और एबनॉर्मैलिटी को आइडेंटिफाई करो. दैट यू शुड बी एबल टू आइडेंटिफाई दिस एबनॉर्मैलिटी. यू डोंट नीड टू रिमेंबर दिस एबनॉर्मैलिटी, and based on that identification you have to mark the correct answer. Like what are the deformities? Because CTEV se related there are 3 questions only. One is deformity, second one is management, and third one is brace. So what are the deformities? One of the deformities is equinus. One of the deformity is equinus. Now what is equinus? It is fixed plantar flexion of the ankle. Now as you can very clearly identify in this case that here the foot is in real, to some extent it is plantarly flexed. That equine is the word which is used for horses. Normally hota kya hai human beings ke andar, that the long axis of the leg, long axis of the foot, they are perpendicular to each other. But in case of horses, they are having relative inclination of these two axes. But in case of human being, in case of a child who is born with this abnormality, the axis of the foot and axis of the leg are inclined, जिसकी वजह से ये deformity बनती है CTEV. Another deformity is forefoot adduction, or you can say the inversion of the foot. Another deformity is inversion, right? Then there will be adduction of the forefoot. So basically ये 3 deformity के ही basis पे you would be able to identify a CTEV abnormality. Apart from this, there is cavus and internal rotation of tibia. Cavus and internal rotation of the tibia, right? So these are the clinical features on the basis of which you will identify a CTEV deformity. So you can see over here that the foot is inverted, the forefoot is adducted, and this is how you will identify a club foot deformity, this CTEV deformity, right? तो एक तो आपको deformities के बारे में मालूम होना चाहिए, और यही deformities are responsible for naming it. Like congenital means since birth, tally means ankle joint, pes means foot. तो जो abnormal यानी congenitally ankle and foot are abnormal. Now what are the basic abnormalities? One is equinus deformity, other one is varus deformity. तो ये तो हो गया identification. So as far as management in newborn is concerned, तो treatment में होता क्या है कि newborn में आप जो है उसकी deformities को gradually you correct, and that treatment is achieved by Ponseti method. So Ponseti method is used in the management of this condition. That is, तो उसमें gradual correction of all the deformities simultaneously, and the first cast is applied as early as possible. And once all the deformities are corrected, जैसे ही सारी deformities correct हो जाती है, then the corrected foot is placed in Dennis Brown splint. This is Dennis Brown splint. And why is it placed? What is the aim of placement? The foot in Dennis Brown splint till the age of walking is to prevent the recurrence, ताकि ये दोबारा ये deformity ना बन जाए. So in order to prevent the recurrence, Dennis Brown splint is used in the management. Now after some duration of time, देखिए Dennis Brown splint का identification is not that difficult. There are 2 feet which are connected. There are 2 shoes which are connected by a bar, and both the shoes are kept in abduction and slight amount of eversion. Now after some duration of times, मतलब 1 साल बाद 2 or 3 to 4 years from now, the question is going to be asked on SFAB, that is Steenbeck foot abduction brace, because this is also a slight modification of this Dennis Brown splint. And how is it is very easily identified that instead of a bar we are having a rod, and the abduction is all the way up to 90 degrees. So that is SFAB, Steenbeck foot abduction brace, जो कि future related आपके questions होंगे, right? Okay, so that was about CTEV. CTEV से related, there are 3 facts which they are asking. One is deformity identification, second is the management, Ponseti method, and finally how to identify the DB splint and what is the role of this splint. The role is to prevent the recurrence of the condition. Now another condition which is likely to be asked in future is Perthes disease. And how will you identify a Perthes disease X-ray? You know, the main full form of this condition is leg-calf Perthes disease. The condition is leg-calf Perthes disease. And how you are going to identify it on the X-rays? So as far as these two hip joints are concerned, if this is the right side, this is the left side, obviously the right one is normal, the left is abnormal. Now, as you can very clearly see that the epiphysis is flattened. So here the patient is going to have a flat epiphysis. And despite the fact, when you compare both these two epiphyses of the hip, when there is so much of the abnormality which has already happened in this case, despite this fact, the hip joint space is normal. That means there is no reduction of the joint space. क्योंकि आपके इस क्वेश्चन के ऑप्शन में tuberculosis will always be mentioned. And how to differentiate it with tuberculosis? Because in tuberculosis, there will be early reduction of the joint space. But in this case, Legg-Calver-Perthes disease, which is avascular necrosis of the epiphyseal head of the femur, all right, there is no reduction of the joint space until the secondary osteoarthritic characters starts or begin to happen, right? So एक तो ये तरीका है identify करने का. दूसरा means there are other points also, like there will be metaphyseal widening, there will be metaphyseal calcification, there could be lateral subluxation, there could be proximal migration, right? But this is how you are going to identify the condition, that is Legg-Calver-Perthes disease. Now, every time you get a question related to Legg-Calver-Perthes, the two of the most important clinical features which will be provided to you, one is a stereotypical picture of the child, that is thin-built, overactive child. That means the child is going to be overactive, thin-built, extremely disturbing kind of the child, continuously running kind of the child, overactive. The age group would be provided in between 4 to 8 years of age, and particularly it is seen in case of males. And one of the pathognomonic clinical feature on the basis of which you will almost confirm the diagnosis is limitation of abduction and internal rotation. So limitation of the abduction and internal rotation of the hip joint. तो इस तरह से आप Perthes disease को identify करोगे on the X-rays made, right? If you go back, means again, if you want to see it again, like if you can very clearly identify that this is the normal epiphyseal head of the femur on the normal side, and this is the epiphyseal head of the femur on the abnormal side, and there is a huge difference in between the two. There is a flattening of this epiphysis, right? Next, another condition which is likely to be asked in your examination is the X-ray of the developmental dysplasia of the hip joint. You know, developmental dysplasia of the hip joint से related जो questions पूछे जाते हैं, these are majority of the times are related to its screening for or screening investigation, that is ultrasonography. But as the child grows, you can very clearly see that if you draw a line which is horizontal, that is known as Hill-Jenriner line, and another line which is outer border of the acetabulum, that means which is passing through the outer border of the acetabulum, is known as Perkin line. So both these two line intersection at the individual hip is responsible for creating a quadrant. A quadrangular space is created. Now, as you can see, normally the epiphyseal head of the femur is present in the inner lower quadrant. So this is the location of the inner lower quadrant, normal head of the femur. But in case of developmental dysplasia of the hip or dislocated hip joint, the epiphyseal head of the femur is present in the upper outer quadrant, right? So it is present in the upper outer quadrant. So this is how you are going to identify this developmental dysplasia of the hip X-rays. Now there are other X-ray findings also, like in this case, if you draw a tangent through the floor of the acetabulum and create an angle, calculate the angle in between Hill-Jenriner's and this tangent, then this angle is known as acetabular index. And this acetabular index normally it is less than 30 degrees. But in case of developmental dysplasia of hip, which can be very easily identified from here, that this angle is obviously more than 30 degrees, right? So this is another way of identifying the DDH X-rays. And the third way, the last way of identifying this developmental dysplasia of hip X-ray is that if you draw a line through the center of the neck proximally, then it is passing through the acetabulum. So it is crossing the acetabulum. But if you draw a line on the affected side, it is not passing through the acetabular surface. It is not passing through the articular surface of the acetabulum. So this line is known as von Rosen line. So this is how you will identify the X-ray of the developmental dysplasia of the hip joint, that is DDH. Now, as you already know, the important clinical features related to developmental dysplasia of the hip joint are that there will be Ortolani test. Ortolani means reduction of the hip joint. There is going to be Barlow test, which is dislocation of the hip joint. And most importantly, what is the screening investigation in case of newborn? The screening investigation in newborn is ultrasonography. और ये developmental dysplasia of hip होता क्या है कि the acetabulum is abnormal in shape. Acetabulum is created shallow. Acetabulum is developmentally abnormal, where the shape is relatively shallower, so that the head of the femur can be very easily dislocated. Head of the femur can very easily come out of this acetabulum. That results in congenital dislocation of the hip. Although it is a huge topic that we have discussed already, but as far as your examinations are concerned, जो 3 part इसके अंदर that you have to remember are identification on the X-ray, screening investigation of the choice, and the most important part is the management. That means treatment in newborn. You see what happens in case of newborn. The aim of the management is to keep the hip reduced. Ultimately, आपको hip joint को reduce रखना है. That is the aim of the management. So the aim for the management is hip reduction. Now, this hip reduction is difficult क्योंकि आप उसकी abduction position को continuously hold करके नहीं रख सकते, and this might also get dislocated again and again. So to prevent this dislocation, the hip joint is kept abducted in a splint or a brace, and this splint is known as Paulick harness. And there is always a possibility that they might ask you by giving the picture for the purpose of identification of the Paulick harness. Now, how will you identify a Paulick harness splint? Now, as it is very clearly seen over here, that the hip joint are kept abducted, that the hip in abduction. So these belts and the braces are tied along the ankle, along the body, in order to keep the hip joints abducted, but with mobility allowed. Right? So to some extent, the mobility is allowed, even though the hip joint is kept in abduction position, but some amount of mobility is allowed. आज हम use करते हैं Paulick harness, but not long back, von Rosen splint were used in the management of DDH in the newborn. Von Rosen splint, but उसके साथ disadvantage था that it was holding the thigh in abduction, and that was a stiff abduction holder. मतलब hip joints were fixed in abduction. So when any splint that holds the thigh in fixed abduction will result in no mobility. And when there is no mobility at the level of hip, the complication of osteonecrosis head of the femur increases. So it resulted in increased complication rates around the epiphyseal head of the femur, which goes into avascular necrosis. In order to prevent it, Paulick harness came into existence, and Paulick harness is a better splint to be used for the management of developmental dysplasia of the hip joint. So hopefully everything is clear. A question which gained entry for the first time in 2017, and since then this question has been asked multiple of the time, as you can very easily identify that the shoulder of the, or you can say the scapula blades or the shoulder blade on the left side is different from the shoulder blade on the right side, and both of them are asymmetrical. Problem ये है कि जब भी हमें कोई image दिखाई देगी back की, where there is an abnormal prominence of the shoulder visible, then we will go in the favor of winging of scapula. And this obviously would be kept in one of your options. But here, what is happening over here is that one of the scapula is higher compared to the other. So this picture is identified as a Sprengel shoulder. This is not winging of scapula. And how will you identify a Sprengel shoulder? That there is going to be asymmetry as far as the level of the shoulders are concerned. Asymmetry in shoulder level, क्योंकि problem ही ये related to descent of the scapula से है. Like up to 12 weeks of gestation, the scapula comes to a thoracic location, but if there is a developmental abnormality which results in one of the scapula higher compared to the normal, that is Sprengel shoulder. As far as winging of scapula is identified, the winging of scapula के अंदर there will be prominence of the medial border of the scapula. there will be prominent medial border of scapula. All right. And that over prominent medial border of the scapula will result in that over prominent medial border of the scapula does not mean that both of them are asymmetrical. The level of the scapulae are going to be on the same side. And one more point is, जब भी आपको swinging scapula से related image मिलेगी, then there is going to be action pronounced. That means the patient is going to perform some action in the form of a pushing a wall. और back की image होगी, and that image is going to be with the action oriented to make this medial border of the scapula more prominent. All right, this is how winging of scapula is identified. Back की images के लिए कुछ और differentials भी हो सकते हैं, like injury to spinal accessory nerve. Now, you know what happens in injury to the spinal accessory nerve, 11th cranial nerve, which is responsible for supplying this trapezius. So trapezius atrophy भी होगी. So it will result in trapezius atrophy, right? And finally, one more image which could be provided as a differential, the back image, is that of a scoliosis, right? And scoliosis is very easily identified. It is the lateral curvature of the spine. Simple. You can very easily identify it as a lateral curvature of the spine. So hopefully everything is clear related to the topics that we have discussed, which are very common nowadays. And in this segment, what we have covered, in the recall, what we have covered are the CTEV, in particularly a very hot question, a kind of the question which is in trend. And why not? Because the examiner wants you identify the condition, counsel the parents, give them the correct direction that this condition is manageable with a simple application of the cast, right? That is Ponseti method. So hopefully you found this session helpful for your future examination. All the best for your INI-CET examination. All the best for your NEET PG examinations, right? Take care. Thank you very much.